Endoscopic antenna coupling, a new mechanism for injury. Diagnostic and therapeutic upper and lower endoscopy is being done with increasing frequency. Fortunately, complications are quite rare, but can be devastating if not immediately identified and addressed. This can be especially difficult in patients who suffer delayed bleeding or perforation, often several days after the procedure. Multiple theories exist as to why this occurs, but today we will demonstrate a new mechanism for this injury. The presentation of this energy-based phenomenon is very timely, as endoscopy is being used for increasingly complex procedures that incorporate significantly more surgical energy than has been used in the past. And as we all know, increasing energy use is associated with increasing complications. To better understand energy coupling, we must briefly review the concept of antenna coupling, which has only recently been described. Antenna coupling is the transfer of radio frequency energy from an active antenna to nearby conductive materials without direct contact. An antenna, or in the case of surgery, an electrocautery device, or BOVI, when activated can transfer energy through the air into nearby cables or wires. For example, a laparoscopic camera or light cord, neuromonitoring cables, or even an esophageal temperature probe. This has now been demonstrated in multiple studies and can cause significant thermal injury to patients. As this video demonstrates, so much energy is transferred that we can see, smell, and even hear energy arcing from the telescope tip to the tissue. Subsequent studies have further defined practical steps that can be taken to minimize the coupling of energy. This includes decreasing the energy used by reducing the power setting or selecting a lower energy mode, such as cut or blend mode, in contrast to the standard coag mode. In addition, separating the active electrode or BOVI cord from other cables has been shown to reduce the incidence of burns in a randomized controlled trial. Unfortunately, the very design of endoscopic equipment is a perfect setup for energy coupling. The active electrode is placed through the working channel and is always in close proximity to the endoscope itself. The working channel and camera cable are insulated against the direct transfer of energy. However, antenna coupling does not require direct contact and only requires close proximity and parallel alignment for significant energy transfer. To prove this concept, we used a therapeutic endoscope and a standard endoscopic snare that was connected to a generator on baseline coagulation settings. The snare has been retracted into the working channel to maximize our visualization. As expected, we again encountered arcing of energy directly from the endoscopic camera lens to the tissue. These findings were confirmed with a FLIR thermal camera. The white color depicts temperatures near or greater than 100 degrees Fahrenheit. On repeated testing, we noted temperatures as high as 300 degrees Fahrenheit. With energy arcing directly from the camera lens to the tissue, it would not be visible to the endoscopist during a procedure. As a result, a perfect polypectomy or submucosal dissection, even without a full thickness injury, could still result in a delayed perforation or bleed at a separate site where the energy arced directly to the tissue from the camera lens, all outside of the endoscopist's view. To our knowledge, this is the first demonstration of unintentional energy coupling during endoscopy. This provides an alternative mechanism for delayed injury. Further study is needed, but in the meantime, it is prudent to recommend a general reduction in power settings to the minimum required for safe tissue dissection. Thank you.